Listen, speak and ask. Touch and then scopy, echoscopia and endoscopia if necessary, and if even more necessary, MR or CT scanning. First transversum carcinoma we found by echoscopia first. Acute diverticulitis with clinical symptoms. Abscess formed by acute diverticulitis. Long covered abscess formation in an acute diverticulitis. Acute diverticulitis, once more again, note the site palpation at the end of the video. Abscedating diverticulitis with the details. Amyloidosis combined with an acute diverticulitis, conservative treatment. Acute infiltration with urinary bladder infiltration. Abscedating diverticulitis and puncture, fine needle puncture. Acute diverticulitis with the CF, which renders little additional information. Acute diverticulitis and pneumaturia as a further complication. Non-specific self-limiting colitis with the thickening of folds and walls. Vaginal tamponade during menstruation. Adhesion ileus after operative intervention. The focal lesion FL at the liver margin is much more apt to bleeding risk than the other one, which is covered by liver tissue with less perfusion. Normality of elasticity and of anatomy in this fine transverse section. An autoimmune pancreatitis in histology confirmed by operation. Scheme with more detail of left liver lobe in the small figure. You can see the coordination of bile duct branches and of portal vein branches. Exchange is needed, exchange of the stent as indicated by the obturating masses. Correct position and function of a PTCD stent. Correct transverse section anatomy as well, and please observe bulbous with gas. Perforated ulcus bulbi, please note the site of perforation. Lipomatosis of the vulva, no pathology at all in hydrocolonosonography. Lipomatous pancreas, as often in the elderly, no pathology again. Heavy acute cholestasis with liquids surrounding the gallbladder. Ascending colon carcinoma, so to say the old women carcinoma, as Professor Johan Sporea in Romania notes. Acute appendicitis with all clinical features wanted, and once it is up, right down, and once it is downside. Aphlegmonous diverticulitis seen by echoscopia and endoscopia. Colitis ulcerosa, which ended in this young individual in a total colectomy. Urinary congestion grade 2, out of 3 grades. Urinary congestion again, now grade 2 to 3, and observe the blocking lymph nodes. As well, lymph node occlusion is shown, and it results in a congestion grade 3. Please always exactly normal anatomy. This is mandatory. Renal vein partial thrombosis in an chronic alcoholic. Finding the way of orientation by bats, Mr. Spallanzani. Vascular architecture in liver cirrhosis, as above in figure 40, and in sections, in casts, and in vessel representation, in live in figure 41 left, and in US as well in figure 41 right. Vascular architecture in biopsy described as chronic active hepatitis. Borders are transient, and we quote Mr. Bianchi, who said, each cirrhosis is an individuum. Cimetidine-induced acute hepatitis leading to death. Consistency augmented in a known liver cirrhosis. Observe especially the heart beats against the liver. Liver protrudes into the gallbladder. It was metastatic. Reflex-rich, figure 46 1a, and reflex-poor, figure 46 2a and b, HCC with a different vascularization. The smallest HCC we found ever. Here, lymph node metastasis of a neuroendocrine tumor had to be described, whereas in here it was a carcinoma of the sigmoid. In here it is documented a bleeding and a hematoma after renal ESWL, extracorporeal shockwave lithotripsy. In case figure 51, there is the unusual case of a malignant primary tumor of the os pubis. This case in here in figure 52 is repeated on purpose to better show the free gas in the arrow region. A paraproctical abscess in a severe Crohn's disease. A herniation in a rather fat individuum is shown here in case figure 54. A long-standing Crohn's disease is in here in case figure 55. This lady suffered from mammacarcinoma at the left flexure. The thickening of this area was either due to a metastasis or rather a malignancy of its own. This wall thickening in case figure 57 was due to chemotherapy. This focal lesion was observed after a laparoscopic procedure. A difficult-to-see corpus carcinoma in case 59. Wall thickening in here gave the suspicion of an ovarian malignancy. Normal terminal esophagus with thin layers. Dislocated esophageal prostasis and an esophageal malignancy in case figure 62. Free gas to the left as seen from the observer and intestinally captured gas to the right. The case of hepatolithiasis is, as here in figure 64, seldom in Europe, but in Asia it is frequent. Intestinal invagination is found in figure 65. This pleural effusion in case figure 66 explained the clinical symptoms of dyspnea. Another case in figure 67 of a long-standing Crohn's disease of the left flexure is again shown in figure 67. Normal flow conditions are seen here in the periphery in figure 68. This easy maneuver outrules a thrombosis in figure 69. After eating, stomach is here full in figure 70, full of ingesta. Another impressive case of acute cholecystitis in case in figure 71, chronic cystitis of the urinary bladder produced this wall thickening in figure 72. These lymph nodes in case figures 73 were due to a metastating malignant melanoma which had been taken place 10 years before. In 74 you see by merely macroscopic evaluation a typical malignant melanoma particle after biopsy. After explorative laparotomy in case in figure 75, some perirenal gas could be found for some more days. A shock showed angionecrosis led here in figure 76 A and B to these interesting features.